Assalamu alaikum. I am Dr. Hamdi Abdelhadi, MD, Consultant Urogynecology and Reconstructive Pelvic Surgery, Urogynecology Unit, Ain Shams University. Today I will be speaking to you about overactive bladder and how to manage it. Definition: the International Continence Society defines overactive bladder syndrome as urinary urgency, frequency, and nocturia with or without urge urinary incontinence. The overactive bladder occurs in both men and women. In some patients, it is accompanied by uncontrolled contraction of the detrusor muscle during bladder filling, which is called detrusor overactivity. So, overactive bladder is a term for a group of symptoms which are frequency, urgency, nocturia. It can be wet overactive bladder or overactive bladder with urge incontinence, or dry overactive bladder, just the symptoms but without incontinence. Urgency incontinence is the most bothersome symptom of overactive bladder and is reported in around 20% of men and 40% of women with overactive bladder symptoms. So the most distressing symptom in overactive bladder is urge incontinence, which means that presence of urge incontinence alone affects the patient's quality of life and affects her more than the other symptoms. Frequency, which is more than 8 micturations per 24 hours. Nocturia, normally any male or female, they wake up at night, urinate just once. If it became 2 or more waking up at night, more than 2 times, then it's called nocturia. So nocturia is 2 or more waking up at night to void, with or without incontinence, just void. Okay, so waking up at night just once, this is the normal. This is not nocturia. Nocturia is more than that, 2 or more. Okay, the reported prevalence of overactive bladder in females varies between 7.7 and 31.3%, and in general prevalence rates increase with age. So about symptoms, about 30% of females have at least 1 or 2 symptoms of overactive bladder. You see here the patient, this lady is rushing to the toilet to avoid wetting herself. This is urgency. This is what we call urgency. Physiology of bladder control. We have the sympathetic system, we have the parasympathetic system, and we have the somatic nerve system. Sympathetic system, originating from T11 to L2 segments of the spinal cord, is responsible for urine storage and control. Stimulation of the sympathetic nerve system results in contraction of the urethral sphincter with relaxation of the detrusor muscle, allowing the bladder to accommodate urine and inhibiting micturition reflex. So the sympathetic is responsible for storage of urine. The parasympathetic and the somatic nerve system originates from S2 to S4 sacral plexus. These nerve fibers causes either sympathetic or somatic stimulation, causes contraction of the detrusor muscle and relaxation of the external sphincter, resulting in initiation and maintaining الvoiding. يبقى sympathetic thoracic لحد اللمبر 2. These are responsible for bladder control. The parasympathetic and the somatic are responsible for initiation and maintaining voiding. Pathophysiology of overactive bladder. In cases of idiopathic overactive bladder, which is the most common in females, the pathophysiology is activation of the M3 receptors. The bladder is filled with M3 receptors, muscarinic receptor type 3. This activation of these receptors lead to the detrusor contraction, which in turn leads to urge incontinence. So what causes activation of these receptors? 2 theories. First one is that there is increased sensitivity of the receptor itself, is more sensitive than usual for the acetylcholine. So any small amount of acetylcholine will cause firing of these receptors, leading to detrusor contraction and urge incontinence. And the other theory is that there is leakage from acetylcholine from the presynaptic parasympathetic nerve terminals, resulting in overactive bladder. So the presynaptic nerve terminals storing acetylcholine, there is leakage from these presynaptic nerve terminals. So this leakage causes activation of the M3 receptors, which in turn leads to contraction of the detrusor and urge incontinence. So these are the two suggested or hypothesized mechanism of idiopathic overactive bladder. Etiology, two types, neurological and non-neurological. Neurological, spinal cord disease, stroke, multiple sclerosis, diabetic neuropathy. So any neurological disorder causing imbalance between the sympathetic and parasympathetic nerve system will result in incontinence or overactive bladder. Then we have another type which is more common than neurological, is the non-neurological causes. For example, cystocele, bladder stone, chronic urinary tract infection, interstitial cystitis, urogenital atrophy, bladder outlet obstruction. If you have something obstructing the urine outflow, then there will be reflex detrusor overactivity and overactive bladder. Low compliant bladder, for example, after irradiation, any pelvic irradiation will result in bladder fibrosis or fibrosis of the elastic tissue around the bladder, and the muscle will be stiff, the detrusor muscle also. So it will result in low compliant bladder and symptoms of overactive bladder. Mass compressing from the outside, example, if you have a cervical myoma, it's not allowing the bladder to distend properly. So any few amount of urine in the bladder, the patient will complain of frequency and urgency. And the commonest cause in female is idiopathic. This is the commonest cause of overactive bladder is idiopathic. Approaching diagnosis. Diagnosis of overactive bladder requires exclusion of infection, other pathological conditions, like we mentioned before. In complicated cases, urodynamic study can be valuable. Initial assessment includes history, abdominal, pelvic examination, and rectal examination, neurological examination. Investigations include urine analysis, urine culture and sensitivity if needed, post-void residual volume, pelvic and bladder ultrasound. In some cases, cystoscopy is indicated. Approaching diagnosis, history, we'll ask about how many times does the patient void per 24 hours, which is called frequency. We'll ask about urgency. Does she have the urge to go to the bathroom? If she have the urge, she cannot hold herself. We'll ask about urge incontinence and stress incontinence. And there is what we call stress-induced urge incontinence. The patient complained that after coughing or sneezing or something like that, anything to increase her abdominal pressure, 1 or 2 seconds after coughing or finishing coughing, she starts to have an episode of urge incontinence. Nocturia, does she wake up at night to void? How many times? Dysuria, painful micturition. Nocturnal enuresis, did it happen before, during childhood or during adulthood? Pelvic pain, loin pain, dyspareunia, recurrent urinary tract infection, pelvic surgery. Symptoms of urogenital atrophy, for example, vaginal dryness, recurrent vaginal infection. Is she menopause or not? We'll ask also about weak or interrupted stream. We'll ask about relation to coitus. Does she leak during orgasm or during penis introduction? Rough estimation of the amount of urine that leaks from the patient. Does she leak a few drops or a gush of urine gets out from her? Any neurological disorder? Does she have any history of neurological disease or vertebral column disease? We'll ask about previous pelvic surgery. Did she have any vaginal repair or cystocele repair or myomectomy or hysterectomy, anything in the pelvis? We'll ask history about diabetes and if it is controlled or not, and medication taken. We'll ask about diuretics, anticholinergic medication. We'll ask about glaucoma. By the way, there is a new medication for treating diabetes mellitus, and this medication causes recurrent UTI and recurrent vaginal infection with urgency. We'll ask about it also if she's taking this new medication. Yeah, I think it's called, for example, I said sodium glucose co-transporter 2 inhibitors. For example, there is a drug called empagliflozin. Okay, this medication causes polyuria and glucosuria, and patient will come complaining of recurrent urinary tract infection plus urgency plus vaginal infection. So we have to take good history about the medication she's taking and if she's diabetic or not, and what medication she's taking for diabetes. What's her latest glycated hemoglobin? Is it controlled or not? We'll ask about glaucoma because glaucoma contraindicates anticholinergics if we are going to use anticholinergics medication for treatment of overactive bladder. So we'll have to ask about any eye surgery or any increase in the pressure inside the eye. We'll tell the patient to fill her voiding diary and see how much fluid does she take per day. Is she taking caffeinated products? Is she taking a lot of compulsive water intake? May result in urgency and frequency. Also, if we have a lot of qualitative questionnaires evaluating impact of overactive bladder on quality of life, like the International Consultation of Incontinence questionnaires, ICIQ. These questionnaires will evaluate the impact and the severity of the urinary incontinence for these patients. So after finishing history, then we go for examination, general examination, including abdominal examination for any pelvic mass, pelvic scars, loin pain, tenderness in the loin. Also, we'll do pelvic examination. Plus, neurological examination is very important if there is any neurological deficit or any spinal cord scars or surgery or mass or something like that. We'll examine any neurological deficit in the lower limbs or the perineum or the lower abdomen. Vaginal examination for genital atrophy. Also for prolapse if she's having cystocele or rectocele or uterine prolapse, if she has a paravaginal or midline defect. We will examine for bladder tenderness, bladder mass, vaginal infection. We'll look for cervicitis. We'll look for stress incontinence by performing car stress test. Basic investigation for case of overactive bladder is urine analysis, urine culture and sensitivity, pelvic ultrasound, bladder ultrasound. Here, the bladder ultrasound different from pelvic ultrasound. Pelvic ultrasound, we evaluate the uterus, the adnexa, the pelvis as a whole. The bladder ultrasound, we evaluate the bladder size and bladder volume by ultrasound at full bladder. Then, after the patient goes to evacuate her bladder, we redo the scan again to evaluate the residual volume. Also, during bladder ultrasound, we measure the bladder wall thickness. Normally, it is less or about 3 millimeters if the bladder is full, and from 4 to 5 millimeter in empty bladder. Urinary tract ultrasound, we'll search for any back pressure on the kidneys, hydroureter, hydronephrosis. From the investigation, also blood sugar, glycated hemoglobin, high vaginal swab if there is a vaginal infection, renal function, especially if the patient is having long time of overactive bladder with back pressure on the kidneys. Urodynamic and cystoscopy in selected cases. Urodynamic findings in the urodynamic are you can find it clearly in the lecture about urodynamics for gynecologists. You will know what to look for and what is the findings in case of overactive bladder during performing urodynamic study. Cystoscopy is indicated if there is suspicious of bladder mass or stone or interstitial cystitis. Management strategy. If a specific cause is identified, it will be treated appropriately. For example, urinary tract infection, give antibiotics. Atrophic vagina, atrophic urogenital tract, give topical estrogen, vaginal cream. If there is cystocele, treat the cystocele. If there is mass complaint in the bladder like fibroid, remove the fibroid. So if you have a specific reason, eliminate this reason first, then reevaluate the patient. Then for idiopathic overactive bladder, which is more common, treatment approaches include 3 strategies: behavioral therapy, pharmacotherapy, and surgery. Guidelines for the treatment of overactive bladder by American Neurological Association in 2019. First line is behavioral therapy. Second line management, pharmacological therapy, including antimuscarinics or beta-3 agonists, adrenal receptor agonists. They can be combined with behavioral therapy. Third line, including BOTOX and injection, posterior tibial nerve stimulation, and sacral neuromodulation. And the fourth and the last line of management, which is augmentation, cystoplasty, and urinary diversion in refractory cases. Behavioral therapy, which includes scheduled voiding regimen. We tell the patient to evacuate her bladder regularly every 1 hour, then increase the duration to 1.5 hours, then 2 hours, and tell her to hold her bladder between these voids. Pelvic floor muscle training is recommended as a first-line therapy by the International Continence Society. We refer the patient to a physiotherapist or urogynecology nurse to teach her how to perform her pelvic floor training. Dietary measures: avoiding alcohol, avoiding spicy food, chocolate, avoided carbonated and caffeinated beverage, high fiber diet, treatment of constipation. All the factors that increase the overactive bladder symptoms are avoided when performing behavioral therapy. Electrical stimulation. There is a machine done by Labori called the Urgent PC. It is an office-based method for neuromodulation that uses percutaneous tibial nerve stimulation via needle electrodes to deliver retrograde access to the sacral nerve. The patient takes 12 sessions. Each session is 30 minutes, finished in 3 months, followed by a maintenance regimen. This electrical stimulation or the urgent PC is effective sometimes when medication fails. It gives very good results. This is the urgent PT device, and this is how it is used. A ground electrode and a needle electrode is placed on the tibial nerve, and the machine is switched on. Pharmacological therapy. Anticholinergic and beta-3 agonists are currently used therapy for overactive bladder. The goals of the therapy are to prevent inappropriate detrusor contractions and to maintain normal bladder function. The duration of the treatment is controversial and may last for years. Overactive bladder is a chronic condition, and the patient may use the treatment sometimes for life. Anticholinergic drugs, the gold standard and the old medication, oxybutynin or Uripan or Detropan, is a 5 milligram tablet We can start with 1 tablet per day up to maximum 3 tablets. Dry mouth is the cause of discontinuation regardless of efficacy. It was the gold standard for treatment of overactive bladder for 30 years. Anticholinergic drugs like sulfenacine or Visicare, M3 receptor selective antagonist. Dose range from 5 to 10 mg per day given single dose. Equal efficacy to oxybutynin, but less side effects and better patient compliance. Of course, both of them are contraindicated in glaucoma. Both anticholinergics, the oxybutynin and sulfenacine, both are contraindicated in glaucoma. Beta-3 adrenergic receptor agonist. Beta-3 receptors are found in the bladder wall, so when we give a beta-3 adrenoreceptor agonist, it activates these receptors, causing a sympathetic effect on the bladder, which is relaxation of the bladder wall and contraction of the detrusor muscle. Drugs are mirabegron, bitmega, and vibegron, gemtisa. So these are the drugs approved for overactive bladder. Tachycardia is the cause of discontinuation. Expensive drugs, but they are effective. Contraindicated in arrhythmia and hypertension. Recent studies approved it to be used in combination with anticholinergic. Before that, we used not to give both drugs together, the anticholinergic and the beta-3 adrenoreceptor agonist. But studies and recent guidelines approved both to be used together. Local estrogen therapy should be used in all menopausal females. Estrogen increased adrenergic nerve excitability, neuronal influence on the muscle receptor density and sensitivity. Fluoxetine is a selective serotonin norepinephrine uptake inhibitor, believed to stimulate pudendal nerve motor output, which improve urethral closure, pressure, and urethral resistance. 80 mg daily result in reduction in both urge urinary incontinence and stress urinary incontinence episode. This is a very, very effective drug, one of the most effective drugs I have ever used in treatment of urinary incontinence, either stress or urge. This drug can be combined with beta-3 agonist or the anticholinergic, and by personal experience in the field, this drug in combination with the anticholinergic or the beta-3 agonist gives very good results in resistant cases of overactive bladder. Can be combined with other medications. BOTOX injection is approved by the FDA for the treatment of overactive bladder after failure of the pharmacotherapy and the percutaneous tibial nerve stimulation. Botulinum neurotoxin type A is used, repeated annually. Efficacy, 76% of patients are dry within 4 weeks. Expensive, repeated injection, and urinary retention are the causes of discontinuation of this treatment. The most common, or one of the common causes of discontinuation of this treatment is urinary retention. Patients develop, considerable amount of patients develop acute urinary retention after BOTOX injection, and the patient evacuates their bladder using catheterization or CIC, clean intermittent catheterization, which results in patient not willing to continue this model of treatment. Surgical management guideline by the American Urological Association and the Society of the Urodynamic Female Pelvic Medicine and Urogenital Reconstruction suggest that surgical treatment may be offered for carefully selected patients. Procedures include sacral neuromodulation as a third-line option and rarely augmentation cystoplasty or urinary diversion as a fourth-line option for severe refractory complicated overactive bladder. Neuromodulation is a new technique FDA approved for overactive bladder. It requires surgical implantation of a small device at the S3 level. Typically, an external stimulator is placed initially, and if the patient experiences a 50% or greater reduction in symptoms, a permanent internalized stimulator is placed. In 2022, the UK National Institute of Health and NICE supported the use of the Axonics sacral neuromodulator for treating refractory overactive bladder when conservative treatment and pharmacological treatment have failed. Augmentation cystoplasty is rarely necessary in idiopathic overactive bladder. However, it may be used in individuals with refractory neurogenic cases only. If you have neurogenic cases, then you can go for augmentation cystoplasty, particularly in those with poor compliance. In this reconstructive procedure, a segment of bowel is removed and used to replace a portion of the bladder. New modalities in overactive bladder, not yet approved, but appear promising: neurokinin receptor antagonist, alpha adrenal receptor antagonist, nerve growth factor inhibitors, stem cell, antimuscarinic agent, new antimuscarinic agent called imidafensine, a vaginal delivery formulation for oxybutynin to avoid its systemic side effect, then the new beta-3 adrenal receptor agonist solabigrone. These are the new medication that appears promising and still not approved for treatment of overactive bladder. So to summarize, treatment if the cause, if present, if you have a cause for this overactive bladder, like chronic urinary tract infection, like cystocele, like uncontrolled diabetes, patient taking medication causing this condition, anything to causing the condition should be treated first. Then, if you have cystocele, repair it also. Treat constipation, dietary control. If the patient is taking spicy food, caffeinated drinks, stop all this caffeinated drinks and spicy food. Perform pelvic floor muscle training. If failed, then you can start pharmacotherapy. If failed, then you can go for combination of different modality. For example, pharmacotherapy combined two medication or more, and pharmacotherapy plus behavioral therapy, pharmacotherapy plus behavioral therapy plus pelvic floor muscle training. Then if all failed, then you can go for the percutaneous tibial nerve stimulation. Still no improvement, you can go for neuromodulation. Still no improvement, you can go for BOTOX. Still no improvement, then augmentation cystoplasty or urinary diversion. So this is the flow chart of how to treat overactive bladder. Thank you.